Thank you. Thank you so much, Dallas. And thank you, Dr. Milburn, Dr. Shoptaw as well, for inviting me today to this conference. Back in the summer when I was invited to do this, I really imagined that we might all be together, sitting in a room, talking and reminiscing about our experiences over the past year, but we're not quite there yet. But I agree wholeheartedly with Dr. Milburn that it is time to take a deep breath. And so that's what I'm going to do. And just imagine that we're all together today. Could I have my slides? I'm not seeing them. So this is a picture of the coronavirus getting ready to eat me, which is what I feel like happened in the past year. Okay, next slide. So I'm going to try to reflect on the lessons I've learned over the past year and my journey through COVID. From my perspective of being division chief for infectious diseases and the chair of the AIDS clinical trials group. Next slide. You know, it was really a year ago when these first reports of this new virus came out. I was actually in South Africa at the time, and really trying to imagine what this was going to be, what this was going to mean for us in the US and globally. It was, I think I, like many people, did not comprehend the magnitude that this pandemic was going to become. Next slide. And you know when first hearing about it, this global pandemic, high mortality rate for people admitted to the hospital, no known treatment, and a really limited understanding of how to manage people with COVID in the hospital, and the fact that this was highly transmissible. Early on, I think we did not recognize the extent to which it was transmissible from people who were asymptomatic. And that was a major, really limitation of our early understanding. Next slide. So what went through my head? Next slide. I was thinking, how do we prepare to care for people with COVID at UCLA as infectious disease doctors? What will be the impact on people with HIV and the research that we're trying to conduct and move forward? But then I think, like all of you, you know, the other big question I was asking myself is, what can I do to help? How you know, what's my role here? How can I contribute to the response? What could our network, the ACTG, do? And what could we do here locally at UCLA? It was a lot to be contemplating. Next slide. And so, you know, the early response was really the most immediate thing. How do you take care of patients as a physician? And our ID division organized so quickly into setting up our services, understanding how we would process new information, coming up with treatment guidelines, how we would assess the literature, and everybody just jumped on board to organize. So I'm going to talk a little bit about a couple points. What I've learned about conducting clinical trials during COVID as a person whose main focus is in clinical trials and therapeutics, what the impact of COVID's been on the HIV research, and then some of the lessons that I've learned along the way. Next slide. So back in 2000, attending the AIDS conference in Durban, I had the opportunity to hear Nkosi Johnson, the young man who was living with HIV, speak in front of a stadium of people about his experience with HIV. And right now, just the image of all those people packed together in the stadium is just, after we've been so separated, is really kind of mind-numbing to think of everyone being crammed together. But he said, do all you can with what you have, in the time you have, and in the place you are. So I thought back to that at this moment. Next slide. So as was mentioned in March, I got an email from Francis Collins inviting me to participate in this active partnership therapeutics working group. And I, as you can imagine, my hands were pretty full with all the things that were going on here at UCLA. But it seemed like a real opportunity to potentially have some input into where we were going with therapeutics. And this was a public-private partnership that was put together to try to coordinate and leverage existing clinical trials networks and to figure out how to most effectively evaluate treatments for COVID. And also another big goal of this was to coordinate some of the regulatory processes. Next slide. And this group included government partners, industry partners, and several nonprofits as well. Next slide. And it was broken up into a preclinical working group that looked at animal models and in vitro assays of new drugs. And then the therapeutics group, which looked at prioritizing agents for clinical trials. And then there were also groups focused on clinical trial capacity, and then a huge effort related to vaccines as well. Next slide. So one of the key things early on in the therapeutic approach to COVID was just emphasizing the need for rigorous clinical trials. There were so many treatments that were being purported of being effective that were not being adequately studied or being studied in small, uncontrolled experiments and not providing really clear results. And the strength of these kinds of studies is, I think as many of you know, they compare groups that are balanced for characteristics that could impact the outcome. And when we have a new disease, we don't know which factors are important to control for necessarily. So letting the randomization help us out there. And then also when you have a controlled study like this, it gives you an unbiased assessment of outcomes, particularly around safety. So observational studies, which were coming off, in the preprint rapidly, do have value. They really cannot replace randomized trials, especially with a new disease for which the natural history is undefined. Next slide. And the other thing about these randomized trials, though, is each trial in the beginning, when we don't have an effective therapy, has its own placebo group. And the question on the table was, if we really want to try to study multiple agents, do they all really need their own placebo? And can we do this more efficiently? So next slide. To the rescue, I think, come adaptive platform trials. And these are a type of clinical trial that allows you to evaluate multiple strategies using a core protocol in which you can ask different questions, but it allows the placebo arm to be shared across treatments, yielding results sooner than a traditional trial. And you can also, as you learn new information during the study, you can continue to adapt the design. And there's several examples of adaptive platform trials that have been in the field prior to COVID, but really became utilized across the globe. The recovery study, there's a number of them, and I'll talk about one called Active 2. Next slide. So through this active partnership, the ACTG network was activated to develop an adaptive platform trial for outpatients with COVID, and it's got the name of Active 2. Next slide. A protocol team of investigators, several from LA here, Kara Chu, who's now co-PI of the study, and Eric Dar, were brought together to help develop this study. But also at the very beginning of the trial, we formed a community advisory board, which I will also talk about. Next slide. The idea was to try to study early therapies for COVID. Most of the work, early on appropriately was focused on the sickest people who were in the hospital, but we wanted to see if we could develop treatments early on that might prevent people from getting sick and being admitted to the hospital. And the goal of the study was to try to first evaluate things in what we call phase 2 study with a little bit more focus on safety and early signs of efficacy. And then those agents that appear promising would graduate to phase 3, where we would have a larger number of participants and a simpler design. Each of the medications in the study was compared to placebo. They weren't being compared to each other. And then, as I mentioned, from the very start, we assembled a community advisory board nationally, building on our experience from HIV, really identifying early on how essential this would be for the success of the study. The study was planned to have over 100 sites in both in the US and then internationally. Next slide. So one of the things that our community advisory board helped us with was to develop a campaign for the study to help people realize the need for early treatment. And the name of the sort of theme for the study was Rise Above COVID. And the idea was that we are all stuck at home or, and feeling isolated, and that there's something that you can do. So one of the messages in the sort of campaign for the study was helping people become a part of the solution. And we developed a website and a national campaign around Rise Above COVID. Next slide. The trial design was for people 18 or older who were diagnosed in the past 7 days, but not hospitalized, and had any one or more of a number of symptoms. Early on, it was challenging with the delays in testing to be able to get people who'd had their test and had the results back in that 7-day window, but that fortunately has improved. Next slide. The study was evaluating initially infused monoclonal antibodies and is now moving to include pills and injectable, and then actually an inhaled treatment. And then we have matching placebos for these across the study as well. Next slide. In the study, the medications were evaluated in this phase 2, and we check if they're safe, can they reduce oxygen levels, help people feel better, and get rid of the virus. And then if they pass that test, they go to the larger phase 3. Next. And the community advisory board pictured here has really been essential in the developing the study and the messaging. The group comes from around the country, and Tony Wayford from LA has joined the group and has been really instrumental in helping us shape the messaging for the trial and think about our strategies for outreach. We've now added additional members, and this group meets regularly and has provided just essential input into the study. Next slide. The campaign around the study has included social media, as well as lots of work on stakeholder dialogue, working with advocacy groups, and then working with clinical networks that serve underrepresented populations. And we've been fortunate to have support for this through the Operation Warp Speed. Next. So there are a number of challenges, though, in trying to set up a study for people with symptomatic COVID disease. We needed a place to see them. And, we were discouraging people who had COVID to come to clinics and other outpatient centers. And so people had to get pretty creative to develop alternative locations like tents, or pod structures and mobile vans. And these same types of things were needed for vaccine trials that would be potentially seeing people who are symptomatic. Next slide. Here at UCLA, we were really fortunate through the help with the CTSI to develop a small outpatient research center on campus at Lot 27 that includes 3 pods, 2 that are used for patient visits for infusions and other treatments. And these have also been utilized by the vaccine trial for symptomatic visits. Next, and this was actually assembled in less than 2 months. So go back one, sorry. So the Active 2 study now is open at over 95 sites across the country, I think almost in every state, includes sites and community-based organizations, as well as sites involved in the ACTG network. It's enrolled over 1,400 participants, and as I mentioned, is now moving into a phase where it will be evaluating oral treatments, inhaled treatments, injectable, as well as infusions. And Kara Chu has been really leading the protocol as a co-PI over the last several months. And our site here at UCLA has been a leading site in enrollment as well. There's several other sites around Los Angeles too. Next slide. So what about the impact of COVID on the HIV research? We have throughout UCLA so many different activities going on from HIV research. Next slide. And for my role in the ACTG with our sites around the country, in 53 sites in 16 different countries with probably 40 or 50 ongoing studies, there was a lot to do at the beginning. Next slide. We had to, this was just the research agenda of the ACTG, which was mentioned previously, but studies are ongoing in all of these different areas. It's a large study for prevention of multi-drug resistant TB in the field, as well as studies for antiretroviral therapy, viral hepatitis, comorbidities, and neurology. Next slide. So immediately in March, we actually had to pause enrollment in all of our studies to ensure the safety of the participants and to ensure that the clinics were operational and had appropriate PPE and other supplies to protect the staff. We converted many of the visits to remote visits where feasible. We had to do a lot of administrative work to make changes in the protocols for all of this. It was an incredible amount of work to make these changes. But at the same time, we also considered how we could evaluate the impact of SARS on HIV within our ongoing studies. And while our network was only funded really for HIV, we found some ways to add additional questionnaires and collection of samples so that we could look at some of these questions. And then, as I mentioned, the network also pivoted to expand to take on this large treatment trial called ACTIV-2, which I just talked about. Next slide. And we've learned a bit, and I'm not going to go into a lot of details about the impact of COVID on HIV, but there is clear evidence that that COVID can have a more severe impact, particularly on people with low CD4 count who are not on ART. The comorbidities associated with HIV can also increase a person's risk for COVID. So there are people who have heart disease, pulmonary disease, and diabetes. There's a sort of a double whammy. But through some of the work, which I won't go into detail, we have learned, that ART remains effective and people shouldn't be switching their treatment, and that we can, to some extent, postpone some routine medical care, but telemedicine has really stepped in, I think, to help us find ways to remain connected to patients, but still many issues around the isolation and contributions to, pre-existing comorbidities have been a challenge during COVID. Next slide. This was just one study that was presented at ID Week that's looking at this issue of telemedicine and viral suppression in HIV. And basically what they found is that viral suppression rates remained stable, though the number of tests that were able to be done declined substantially. And so while we can maintain, connection with patients through telemedicine, our ability to do monitoring is certainly reduced. And I know there's going to be a lot of interest in this as a new model of how we might supplement some of our care with telemedicine in the future. Because some people do really appreciate not having to come to visit the clinic to have follow-up. Next slide. Next. So some of the lessons that I've learned and are things that I've seen during COVID is that there was a rapid deployment of clinical trials that was built on the infrastructure that had been assembled for HIV care over the last 30 years. And the investment in those resources, I think, really paid off and allowed things to move more quickly. Next. Here at UCLA, some incredible examples. Jesse Clark, Steve Shoptaw, Chris Blades, Will Hernandez, and the entire Vine Street clinical site turned into a vaccine trial site overnight, basically. And they ran the Moderna trial and enrolled over 250 participants, I think, and were able to recruit a diverse sample to the study with their groundwork in the community. Rafi Landovitz and other investigators from the CARE clinical research site, along with the CTSI, have been conducting the AstraZeneca vaccine trial in Westwood. And both of these teams engaged with the community to develop educational materials and extensive plans for outreach. Rafi and Risa Hoffman stood up a Gates-funded study very early on that was a fully remote trial to test hydroxychloroquine for post-exposure prophylaxis for COVID. I mentioned Kara Chu's work as a vice chair for the ACTIV-2 study. And then Otto Yang, a lab investigator, basically came off the lab bench and into the hospital and has led the implementation of multiple clinical trials here at UCLA for therapeutics of COVID. And Thara Vijayan, who leads our antimicrobial stewardship program, led development of local guidelines and also has been managing the distribution of the EUA. But it's because we have all these people here and they have this training that we've been able to do so much. But again, you know, what we see over and over again is that places and institutions with less fewer of these resources have not had the same ability to do this. And this is where I think we continue to need to focus efforts on developing new investigators at additional locations so that this kind of activity is not just localized to places that have these resources. Next slide. We've learned some other things that I think we'll take forward, and I mentioned about remote visits. They could actually improve some efficiency for research studies and in some aspects of clinical care. Being able to conduct an informed consent discussion on Zoom precludes the participant from needing to travel, and I think it has in many instances been really successful. Remote work for all of us has been incredibly challenging, particularly for those who have young children at home and other challenges with having appropriate space to work. But I think that it can provide a little bit of an opportunity in the future we know that people can do it. And then finally, these Zoom conferences are really challenging and hard to keeping people staying attention. But, you know, my optimist side says, I see people being able to comment and have input who wouldn't have spoken up in a public forum. So I think that we should try to embrace that. And then I've also seen that bureaucracies can respond rapidly, and we need to continue to push for that. And then finally, I think the most important lesson that I've learned in this past year, next slide, is that I've been so fortunate to work with the most amazing, dedicated, and hardworking people on this planet. And it's really through the extra effort that everyone has put in that we've been able to accomplish what we've done to date, and we'll be able to hopefully continue to do so much more in the future. So thanks for the opportunity to share some of my journey from the past year, and thank you all for your attention.
Thank you so much, Dr. Currier. Everybody can use their hand clap, Zoom reactions, and so on. So feel free to post questions in the chat, as Dami noted in the chat. And I will facilitate the first few questions. We have about 5 minutes or so. So Tom Bellin from UCLA Department of Biostatistics, with appreciation for your presentation, notably including your creative incorporation of statistics to reinforce other messages in the talk and review of scientific strategies, such as adaptive platform trials. His question relates to his own experience where at times he's encountered resistance when recommending scientific strategies that are unfamiliar to other contributors to decisions. So did you encounter resistance to some of the novel strategies you recommended? And if so, how did you address that resistance?
Yeah, so this therapeutics working group of the active partnership had several biostatisticians on it that really pushed for the utilization of master protocols, and I think they were very influential. Some of the resistance has been in some of the complexity of launching a study like this, but sometimes I think when something comes forward with the weight of the U.S. government behind it, that has been helpful in addressing resistance. So I think that it was just having strength in numbers, and the people that were basically behind some of these ideas were very effective in convincing others to follow this strategy.
Great, thank you. So Dr. Shoptaw says, awesome talk. What do you see as the timeline for when we can return to focusing on HIV prevention? What are your thoughts about getting prevention supplies to people such as condoms, lube, HIV testing, and so forth?
Yeah, thanks, Steve. And I know this has been your question from the beginning, and of how do we get back to what we've been trying to do before this? And I think that I think that we are learning to try to do multiple things at the same time. While COVID is so rampant in our community, we do need to make sure that people are protected, and we do need to focus on getting people vaccinated. But I think being creative about how we get supplies to people, how we get self-testing, or how we get prevention supplies, I think we need to start being creative about that, because being able to return to normal coming to clinics to get things, I think we need more sort of community-based distribution.
Great. And Dr. Landovitz, Judy, thanks for your really wonderful and optimistic but balanced insights. What are you telling trainees whose fieldwork is being derailed or delayed by COVID?
Yeah, this is a common question, and particularly people who have jumped in and gotten involved in COVID work, feeling like how much time should they spend on that versus what they thought they were doing. And I think at the end of the day, you have to ask yourself, what did I do today? Was it useful? Did I help anyone? Was there value to my work? And I think I think the time that's spent by helping with COVID is time well spent for all of us. I think that it's not hopefully going to be here forever. It's going to be with us for a while. But I don't think anyone is going to fault you for spending time working on COVID while you're unable to do other work. So it is there. I think a lot of people are feeling like their research careers are being stalled because it's so hard to work from home and to work remotely. So I do encourage people to get involved with COVID-related work if they can, and there'll be time to get back to other things, hopefully very soon in the next year.
Excellent. Thank you so much. That brings us to time. Thank you again for a wonderful presentation. Thank everybody for their questions. If you have more questions that come up as the information percolates, you can post them in the chat, and Dr. Currier may be able to respond in the chat as she comes and goes throughout the day, and hosting her and attending to all the other wonderful work that she's leading and involved in. So thank you again, Dr. Currier.
Thank you.